on my page. So transfusion of specific component of whole blood needed by the patient is component therapy. Whatever is needed, if it is the plasma that is needed, you give plasma. If it is the red cell that is needed, you give red cell. If it is the platelets that is needed, you give platelets. We hardly give white cell, like I've mentioned, because there is an injection that can be used that is almost free of possibility of transmitting injection, infection. Okay, so we hardly give white cell. So why do we want to use components therapy? Whole blood is the most potent carrier of TTI. What's TTI? What's transfusion transmissible infection? Because there are some infections that are carried in the plasma, there are some carried in the white cell, and some in the red cell, like malaria, plasmodium is in the red cell, CMV, HPV in the white cell, HIV in the plasma, hepatitis in the plasma. So if someone needs one component of the whole blood, why do you want to expose the person to all the risk of infection from the three components? You understand? So that is why it is also imprudent. You know, you in this era of scarcity of blood, you somebody needs red cell, has anemia, and you are giving whole blood that has plasma. It doesn't make sense. You understand? Apart from the fact that the plasma can be a carrier of infection, then you are wasting the plasma for another person that needs that plasma. Does that make sense? And like I said, only one particular component of whole blood is required by most patients at a time. Only one at a time. If you are anemic, you give red cell. If you need plasma, what will make you need plasma? We'll talk about it. You give plasma. And if you have low platelets, you give platelets. Why give whole blood? Have you heard about this before now? You've heard about component therapy before now? I didn't know you've heard about it. So blood products may often be infused regardless of ABO, like cryo precipitates. You don't need to do grouping and cross matching, this and that. You just give, but only with cryo. You know about cryo? Cryo precipitate. We'll talk about it. Okay, so at times you also treat the blood in the process of making it ready. You filter, you can attack, like you've seen a blood giving set before now. Blood giving set. Nobody is answering. You've seen blood giving sets. Okay, blood giving set is what is used to transfuse the blood. You connect, you see infusion giving set now. If you want to take drip, some of you have taken drip. But you also have a blood giving set. It's different from the infusion giving set. So you can then add a filter different from the blood giving set to remove white cell. You understand? So you can filter the whole blood before use. Okay? So it will make it safer. Then nowadays it's possible to donate only one component. Are you aware of that? If you are not aware that I can just donate, take my plasma, return the remaining component to me. Are you aware? That's apheresis. I can donate red cell. Yes, you see the machine, the lecture. There is apheresis machine. It's available at one private facility in Surulere, and maybe a lute, maybe. So apheresis machine, you are connected to the apheresis machine, and then you have a color coded bag to collect your bag, one vein in, one vein out. So to the machine, okay, the cannula going inside your computer vein draws only the component that has been programmed by the machine to draw. When it draws the whole blood, removes the component that has been programmed by the machine into that bag, returns the remaining components back into the other hand. That's a pheresis machine. So, so you can donate only plasma. You can donate only red blood cells. You can donate only platelets. Okay. So when we are preparing patients for transplants, bone marrow transplants, they can program the machine to donate, to extract stem cell from the whole blood. You know, stem cell also flows in the blood. Okay. Of course, after giving the person GCSF to boost the white cell count. Okay. So you can donate. So then you have somebody is 75-year old with a compromised cardiovascular status, and then you are giving whole blood, you know, and the person does not need whole blood. So you can reduce volume and antigen. Then don't forget you have all the antibodies in the plasma. You know, you can be creating problem for the patient. You know, antibody antigen reaction. Okay. So this is how we fractionate whole blood. So you can have fresh cell and plasma, platelet rich plasma. Then you can filter the red cell. You can filter the red to make it gluco reduce. We call it gluco reduce. That's reduce, you want to remove the white cell. Leuco, black white cell. You can freeze, for rare blood group. If the blood is maybe B phenotype, you are coming for a cause, a person is donating, you can freeze indefinitely. In case you meet somebody else who comes around again with Bombay phenotype, it can be lifelong if it's frozen at -150. That's the liquid nitrogen freeze temperature, -150. We have a -80 freezer here. Even -80 freezer is indefinite. Indefinite. So you can freeze if you come across somebody with a rare blood group, you can freeze that red cell and keep it for another user later. And then you can wash the red cell. Those with IgA deficiency that will react to IgA in the plasma, you can wash. Also, the platelets, you can freeze the plasma of the platelets as can be fresh and may not be fresh. And from the fresh frozen plasma, you can produce the cryo precipitates. Can produce the cryo precipitates. I mentioned cryo. Okay. And then from the unfrozen plasma, you can get all your derivatives. Talk about components and derivatives. Maybe I think that's the next slide. Okay. So look at what is called blood components and look at what are called blood derivatives. What is the difference between blood components and blood derivatives. The blood components are blood products that can be obtained by physical measures like centrifugation, you centrifuge, whereas blood derivatives are products that will require chemical extraction. So you can see the derivatives as factor 8. They will need to fractionate it out from the plasma. It don't need to be fresh. It doesn't have to be frozen. All the plasma can be pulled together. You understand? From you, and then make it pathogen inactive. Because you know, plasma is a potent carrier of, I said, hepatitis A, hepatitis B, hepatitis C, HIV, and you know. So if you pull plasma from everybody, you must inactivate all the pathogens in it before you start the extraction. So you can extract with chemicals. Factor 8, what's factor 8 concentrate is for? Factor 8 concentrates. Hemophilia A. Hemophilia A. What about factor 9 concentrates? Hmm? Hemophilia B. Hemophilia B. So albumin is good for hypoproteinemia, patients with low protein. What condition will give you hypoproteinemia? Nephrotic syndrome. Nephrotic syndrome. Or liver cirrhosis can cause happen. You can get immunoglobulin too. Immunoglobulin is your IVIG, intravenous immunoglobulin. It's also useful in some conditions like ITP, immune thrombocytopenic purpura, and some rheumatology condition. We use IVIG. It's very expensive. A day dose may be up to 2-3 million naira, and then you'll be required to take 4 days, 5 days. So it's very expensive. Well, there is a company that came recently. They want to start manufacturing derivatives. So protein PCC is contains all the clotting, 4 of the clotting factors, 2, 7, 9, and 10. So it's also good for some condition like DIC and condition where there is need for deficiency of those factors like 2, 7, 9, and 10. Okay, so those are the derivatives. But the components, there are 2 ways of making components. You use a centrifuge or you use apheresis. I mentioned apheresis. So, like you saw the blood, whole blood, somebody bleeding, you have a centrifuge, like a big centrifuge. You know how a centrifuge is in the lab, but this one is a big one. It's not a bench centrifuge with a big bucket that can contain the bag, whole blood bag. So there, you know, it must be balanced. There are 4 buckets, 6 buckets, 8 buckets. So you put the whole blood inside those buckets after balancing them, and then spin. Which one will settle down first? Which one is the heaviest? Red blood cell, red blood cell. But you would have used a double bag or a triple bag from inception for collection of blood. Have you seen a double bag before? And a triple bag? Okay, so you would have used a double bag if you are interested in only the plasma. So once you spin and then red cell settles down, you now decant the plasma into the second bag if you have used a double bag. Okay, you decant it to the second bag so that you now cut and separate. So you have the red cell concentrate and then you have a plasma. But the plasma contains all the clotting factors, and you have some labile clotting factors. You know them, the labile clotting factors that must be frozen within 6 to 8 hours. Otherwise, they will be lost. You know them, factor 5 and 8. Factor 5 and 8. So if patient has bled, he has been bled into a double bag, and then you have been able to spin and separate. You have been able to spin and separate the plasma from the rest within 6 to 8 hours, and then you have been able to freeze because it must be frozen to preserve it. Then that plasma is known as the fresh frozen plasma. Fresh frozen plasma. Platelet is dissolved in the plasma. So, but it is platelet rich, but it will not be useful because platelet will not survive under freezer temperature. But if you have the intention of preparing platelets along with the FFP, along the fresh frozen plasma, okay, you would have used a triple bag to bleed the donor, okay. So the first process is to spin the whole blood, let the rest settle, decant the plasma into the second bag. I hope you are following me. But if you need the platelets, you will now spin the plasma because platelet is dissolved in the plasma, okay, and you will now let it settle. The second plasma the second bag you have collected, you spin it, you separate the red cell, that's the red cell concentrate. You spin the second bag, the platelet will gravitate just like the red cell, and then you decant the plasma again. So you leave a little plasma with the platelets. That will be a platelet concentrate. You now empty the supernatant, which is the plasma, in the second bag into the third bag. You understand? And leave a little quantity of plasma in the second bag as what? As the platelet concentrates. That is the way to go. If you are using, it is called cold centrifuge or refrigerated centrifuge because you can adjust the temperature while you are spinning. Okay, you can adjust the temperature while you are spinning to 20 if you are preparing platelet, because platelet is better at 20 degrees. Prepared and stored 20 to 25 degrees. That will be room temperature. Okay, but the bottom line is, if you want the labile factor, preparation must be done within 6 to 8 hours. If you do it within 6 to 8 hours, then it will contain all the clotting factors. Like what? Clotting factors like what? One, all the clotting factors now. 1, 2, 3, 4, 5, 6. All the clotting factors will be there in that plasma. So somebody that has hemophilia A, what is the deficiency in hemophilia A? You can give FFP if you don't have factor 8 concentrates. Somebody that has hemophilia B, you can give FFP because it has factor 9. But I can, from my own experience, it is not effective like giving the factor concentrates. So that's why we don't treat hemophilia in lab suit. When we see hemophilia patients, because we don't have factor concentrates, they have in root. Hemophilia Foundation Federation of Nigeria is subsidizing factors concentrates for patients with hemophilia, and Lute is the only site in Lagos. So when we make a diagnosis of hemophilia, we refer them. We can give them FFP just to manage temporarily, but we will still refer them to Lute for the concentrates. Okay, so those are the blood derivatives, and then so for the cryo, I'm going to talk about cryo now. FFP, you know how FFP is produced. How is FFP produced? You spin, you spin the blood, decant the plasma. No, if you are not interested in platelets, if you are not interested, you will freeze within 6 to 8 hours. If you are not, it's when you are interested in platelets, you do a second spin so that you let the platelets settle. So FFP is frozen, must be frozen within 6 to 8 hours. Okay. So even the FFP is like 200 mils, 200 mils, 200. It can be burdensome for those with cardiovascular compromise because you may need up to 6 units to achieve good hemostasis. So that would be like 1,200. Okay. So what is done is to volume deplete the FFP. You can volume deplete it. You can thaw. You know the meaning of thaw. You thaw the, you know it's frozen. Like it's our mother will say defroze. When you bring out, go and bring the turkey and defroze it from the freezer. I'm sure they would have told you. It's thaw. The correct grammar is to thaw. THAW. So you thaw the FFP, you spin and let it settle again. So you decant and leave a little, like a slush in the bag. So if you want to prepare cryo, you have intention of preparing cryo, you would have used a quadruple bag, quadruple, 4 bags, one attached to the other, so that you can decant the plasma of the FFP and leave. So, but we'll talk about the cryo during the lecture. That is our but that is the cold centrifuge preparation. The other way to go is to do apheresis. I've told you about apheresis collection. Collect the donor to the machine, apheresis machine. Machine draws the whole blood, spin, separate the components you are programmed the machine to separate, extract the component into a bag that you have attached to the machine, and return the remaining to the other hand, to the blood, to the body. So you can do that for plasma, you can do that for red cell, you can do that for platelets. Those are the two ways of preparing components. You understand? But we'll continue so that we won't waste time. So I've explained this. These are all you can do. Okay, with the red cell. Okay, you can make it glucose reduced. You can filter it. You can irradiate. Can you imagine? You know irradiation, gamma rays. You know why? Why do you have to irradiate red cell before use? You can wash. We talked about washing with normal saline. And you can make it in a smaller volume, pediatric group. Like the pediatric, some of them will give 10 mils per kg for parcel, and the baby is 4 kilo. How many mils will you give? 40 mils. How many mils is contained in one bag of blood, whole blood? 450 plus 50 anticoagulants, making 500. So, and you need 40 mils. So, if you have means, you are going to be putting needle to withdraw 40 mils, and then you can contaminate the bag. You understand? So, why not get a smaller pediatric bag and bleed the donor directly? Bleed the donor directly into that small bag. So the donor will be donating 50 mils instead of 450 mils. And then you can process. Does that make sense? Because you know in pediatrics, when you start pediatrics, they will ask for, because you don't have pediatric bag in the blood bank, all they have is adult bag. And the patient needs maybe maximum 100 mils. They will ask for grouping and cross matching. Go and get a whole 500 mils bag, draw 100 mils, return, because they cannot keep the remaining blood in the ward. After return it, because they don't have a blood bank fridge, return it to the blood bank. When another patient comes, the same group, no, are you going to be contaminating, introducing infection? You understand? It doesn't make sense. So that is why they thought about pediatric divided red blood cell units. So I told you you can do granulocyte transfusion, that's white cell transfusion, although it is no longer in practice. You can do platelet rich plasma. Which one is PRP? PRP is the one that's the first pin, the plasma of the first pin. Like I said, is rich in platelets. But because you are going to freeze, you are going to destroy that platelets. But if you are not frozen, it is rich in platelets. Because if you are preparing platelets, if you have intention of preparing platelets, after the first spin, I said you do a second spin on the plasma, and then the platelet settles down, and then you decant the plasma, and then the plasma can then be frozen. If it is within 6 to 8 hours, it will be FFP. If it is outside 8 hours, then it is just liquid plasma. You understand? What will be deficient in liquid plasma outside of it? Which one? Factor 5. Do you have other clotting factors? Because the lifespan is the shortest. Those factor 5 and 8 is like 6 hours. So if you don't freeze it, if you want to preserve your turkey, your chicken, once you cannot leave it for one day and then you now start to freeze it, doesn't make sense. It was frozen immediately. Like this Ileya day now, you leave your ram without putting salt. Maybe before you were born, they put salt and keep it till ram. You know about it? Have you heard about it? But because the ram is so expensive now, it's not even enough for the family. Not talk of they want to keep. So if you want to freeze and preserve the clotting factors, it must be done within the span of the shelf life of those labile factors. Okay, so platelet concentrate, we talked about it. The FFP, we talk about it. Liquid or thawed plasma. Okay, we're going to talk about dried plasma. Dried plasma. It's possible to lyophilize, the grammar, to lyophilize, to make it in a powdered form. Yeah, I can get your plasma, lyophilize it, make it in powder, take it to America, and go and give somebody. It's very useful for those during war. You can go with the powder. You go with the powder and take it to war front and label, this is O positive plasma, B positive plasma. So you now reconstitute with normal saline if you want to use it. so that you then transfuse. Okay, so you can do a cryo reduced plasma, like you have separated the cryo from the FFP. You are preparing cryo, you thaw the FFP, you spin, let the sediment settle, and then decant the plasma, the spinal that will be cryo reduced. The spinal will be a cryo reduced plasma, while you have a cryo in the as a sediments. So these are they have talked about it, but like I said, they are not produced here. This clotting factor, immunoglobulin, albumin, they are imported and they are very expensive because of the devaluation of the currency. So they are very, like I said, immunoglobulin, a dose is 2 million to 3 million naira, and then you expect a patient to take it for 4 days. Where are you going? Attendance, don't worry, sit down. When we finish, you take attendance. Is that more important than the lecture you're having? So these are the various that have a whole blood. The packed cell volume, the hematocrit is 40% volume, and then the washed red cell, red blood cell leukoreduce, platelet concentrates, granulocytes, and those are the composition, the volume. So that is about the component, blood component. It's different from the derivatives. Okay, so you have the FFP, the indication for use, and the composition and the volume. This is cryo reduced plasma. TTP is thrombotic thrombocytopenic purpura. Thrombotic thrombocytopenic purpura. And HUS is hemolytic uremic syndrome. Hemolytic uremic thrombotic thrombocytopenic purpura. Thrombotic thrombocytopenic purpura. Thrombotic thrombocytopenic purpura. So these are where they use HUS, hemolytic uremic syndrome. Hemolytic uremic syndrome. Hemolytic uremic syndrome. Hemolytic uremic syndrome. So these are the indications for use of cryo when there is hypofibrinogenemia in DIC, disseminated intravascular coagulopathy. You have low fibrinogen, so you can use a cryo and you can use FFP. You can use a cryo, you can use FFP. Intravascular coagulopathy, or when the deficiency of factor, because cryo is rich in factor 13, factor 8, and von Willebrand factor, but lacks factor 9. So cryo will not be suitable for hemophilia B. So deficiency of stable coagulation factor, third plasma that is outside 8 hours. All other coagulation factors that are not inclusive of labile factors, which are 5 and 8, you can use third plasma. And deficiency of labile and stable fresh positive plasma is rich in 5 and 8. You can see the volume. Look at the volume, 220, and look at the volume of cryo, 15. So at times you are bothered about volume. You don't want to give a volume, too much volume. You are distracting the lecture. So, but at times I'm not saying whole blood use is completely banned, or it's still use it. It's still, you see why we need to use it. So conventionally for 5 we can be stored. Okay, so at times we use a CPDA anticoagulant. What's the duration for CPDA anticoagulant? What are the anticoagulants used? It's not 5 weeks. I guess it's not 5 weeks. Eh? What were you taught? CPDA, what's CPDA? Citrate, phosphate, dextrose, adenine. Those are that is the anticoagulant that is used now. So it's 42 days actually. What are the other anticoagulants? ACD, CPD. ACD is what? CP, you are not ready for the exam. Then what's the shelf life for ACD? 21 days. CPD is 28 days. Then CPDA is 42 days. ACD is acid citrate dextrose. ACD, acid citrate dextrose. But we don't have a cold centrifuge in last. We don't have. So this, and then patient will need platelets. So we usually give fresh whole blood. At times that's why we give fresh whole blood. But we bleed the patient, we bleed the donor, but because the platelet must be kept at room temperature, we put the blood on the shelf, not in the fridge. Okay? And then wait for the screening result to be out. Once HIV everything is negative, then we'll transfuse the fresh whole blood that will be rich in platelets. You understand? So if it is fresh, but fresh definition can be within 24 hours. But I can guarantee you, if you don't give within few hours of collection, the platelet level will drop. So you can, if fresh, 1 unit of whole blood produces 1 unit of RBC, 1 unit of platelet, and 1 unit of FFP. If you can, if you have a centrifuge, you can spin and get FFP and more. The use of whole blood is considered a waste of, why you want to waste, except it's absolutely indicated. Well, so what's the difference? What if you give what's the expected rise in PCV after 1 unit of whole blood? Is there not fixed 3 to 4%? How do they arrive at this? Is the calculation. How they arrive at the 3 to 4%. Okay. So this is average blood volume in man. 70 kilograms is 5,000 ml. So if this man's PCV is 25%, that means the total red cell mass will be 25/100 times 5,000, the total blood volume. If the red cell PCV, which is packed cell volume, is 25%, the total red cell mass will be 25/100, which is the PCV, times the total blood volume. And that will give you 1250 mils. Okay? So if you have given the man 500 mils of blood, 450 mils of blood, and 50 mils of anticoagulant, abi, that's the teaching. If you, the volume, total volume will be 500 mils. Okay? So his immediate PCV will be 1,000, will be 1,450, because the red cell in that whole blood is 200 mils. Then plasma is 250 in the 450. Then 50 is the anticoagulant. That's how they got 500. A packed cell volume, the volume is 200 mils. Okay? So you add the 200 mils to the 1,250 mils, and that will give you 1,450. Then add the 500 mils, the total blood volume, to the 5,000. Now be 5,500 mils, and that will give you 26.4%. But that's not the actual increments. We are starting from 25%. That would have been 1.4%. But body readjusts, and that is why you cannot do a post transfusion PCV 24 hours. What's the time to do a post transfusion PCV? If you do give blood, how long will you have to wait to check the 3% you are expecting? Is 48 hours. The post transfusion 48 hours. Then the post surgery is 24 hours. So you wait for readjustment of the blood volume after 48 hours. Your blood volume will come down because you are going to excrete the excess volume. So come down to 5,000 mils after 48 hours. It will come down to 5,000 mils, and that will impact on the PCV. The PCV will now be 1,450. The red cell is still the same, over 5,000, the new blood volume, and that will give you like 29. So if the donor PCV is rich, so it can be between 26, it can be between 3 to 4% increment. But this one is showing 4, from 25% to 29%. Okay, so it can be between 3 to 4, depending on how rich. So, but at times, like I said, we still need to use whole blood. Somebody that has a road traffic accident, losing plasma, losing breast cell, losing everything, you give whole blood to replace, you know, severe postpartum hemorrhage. Somebody that is bleeding after, you give whole blood. You give whole blood. So DIC, disseminated intravascular coagulopathy, patient is bleeding, you give whole blood. You do exchange transfusion, you use whole blood. Use whole blood for exchange blood transfusion. Okay, so these are the, in severe chronic anemia, there are some contraindication to whole blood use. You don't want to give whole blood in chronic anemia, somebody that is transfusion dependent. You want to reduce, it will reduce the red cell volume and then compensatory increase in the plasma volume. Whole blood adds unneeded plasma to blood and will cause volume overload, like we have agreed, hypoxic myocardial failure. So this is the apheresis machine. You can see the machine and you can see the donor. So you can program the machine to pick only maybe red cell, you can pick only the white cell, you can pick only the plasma. So that is the apheresis machine. Apheresis is available in Surulere, in a private hematology apheresis, and also in Luch. So it is like 700,000 per batch, 700,000 naira for platelet apheresis at Surulere. Is that expensive? So this is red cell. The purpose of the red cell is to increase the oxygen carrying capacity of blood. If you are giving red cell, that's red cell transfusion or pack cell. You know, if you allow it to gravitate without using a centrifuge, that's why it's called a packed cell. But if you use a centrifuge, you can be red cell concentrate. You concentrate it. Okay. So for red cell concentrate, these are the indications. You know, you don't want to give too much volume, particularly patient with congestive heart failure, patients with cirrhosis that have volume, hypoproteinemia, hypoproteinemia, renal failure, hypoproteinemia, nephrotic syndrome, hypoproteinemia will cause anasaka, and then why do you want to give whole blood? You give red cell, okay, so that you don't add more volume to it. In exchange, it may not be fluid enough. If you are doing exchange and you are using red cell, because there is no not adequate liquid plasma to flow. So you use red cell concentrates. So those are the exchange transfusion in neonates using O donor for non, you use red cell concentrates. So these are other indications. Patient exhibiting slow bleeding, particularly from the GIT. Red cell transfusion maintains normal hemoglobin without causing raised central venous. You know, when you are giving red cell concentrate, there is no plasma, there is no volume. So any condition that warrants, so the patient with hypotension is also helped because raised PCV increases blood viscosity with attendant increase in peripheral resistance. So these are the advantages of red cell concentrates or packed cell. You know, two-thirds of the original plasma volume has been removed. So like you have a reduced, so it's good for those with circulatory overload. The plasma, like 250 mils of plasma has been removed in your whole blood. You know, like I said, plasma is like 250 mils. Red cell is 200. Okay, so making 450, and then you have the anticoagulant 50 mils, and that's why you have 500 mils. Okay, so by removing the plasma, you are reducing the risk of circulatory overload and cardiovascular if you are giving red cell concentrate. Or you also, those ones, the sodium, the potassium, hydrogen are also in the plasma. So sodium retains fluid within the circulation, and patient with failing heart may not be able to handle fluid. So by the time you are removing all the plasma, the sodium is gone, potassium is gone, hydrogen that will cause acidosis is gone. So
this part concept, I want to ask, you said, let's say we have to centrifuge, but the back is closed.
you
You
don't
don't
use,
need cloth.
no, but why we need cloth? Because you have anticoagulant in the bag, and we've discussed the anticoagulant ACD, CPD, CPDA. Does the whole blood clot in the bag? Does it clot in the bag? What kind of question is that?
And also, when using this pediatric bag,
Mm-hmm.
I will know that the anticoagulant is 15 minutes. When the
No,
anticoagulant
no. For pediatric bag, it's not 15 mils because it is proportional to the volume of blood, the expected volume. So it's not 50. I'm talking about 50 mils in adult bag, not pediatric bag. That it will be disproportionate if you use 50 mils for pediatric bag. So the manufacturers are not stupid. They know that they will reduce the quantity of the anticoagulants in the pediatric bag. So advantages of red cell include less citrate and ammonia. This is, CPDA has citrates, and then citrate can be converted to the ammonia. So by the time you are removing, so even if you don't have a centrifuge, post centrifuge to separate, if you are the house officer on duty, you can ask for pack cell. What we do is you keep the blood on the shelf and let it settle, and then you decant the plasma. They would have used a single bag. So they will, most of the time, just decant the plasma in the wash hand basin, waste it to get it, because there is no bag to keep it. Apart from that, it will be more than 24 hours, more than 8 hours. So by the time they're asking for blood, so there is even no bag to keep it. So they waste a lot of plasma. Waste a lot of plasma because of the system. So we just open. You've seen a blood bag before. You have a thread. Apart from the position, you've seen a blood bag before. I should have even brought one. So that thread is what you are going to use. You cut it and then put pressure on the bag to expel the plasma through that thread and expel almost all the content. You leave a little bit because the red cell also need little plasma to survive, and then that will be your packed cell. But if you have used a centrifuge, that will be a red cell because it will concentrate it better. You know, you're going to spin it better and concentrate it. But like I said, we used to have, but it's damaged and they've not replaced it. Then there is all the antibodies that are in plasma, anti-A, anti-B, anti. You know, patient is that react to it. So you are eliminating all those. It's immunological advantage. You know, you are not bothered about. So if you have patient reacting to blood, so what we usually advocate is to give them O. If there is O negative, packed, very packed O positive. Just give them, because you are going to eliminate all the anti-A's in the plasma and all the anti-B's in the plasma. If the patient is positive, if the patient is negative, you give negative, O negative. Because the positive rhesus antigen is on the red cell, you understand? It's on the red cell, not. Okay. So we give a very well packed. Most of the time they don't react. If you give them packed, very well packed, because most of the reactions, hemolytic transfusion reactions, is usually due to ABO antibodies and rhesus antibodies. So if you have removed the plasma containing all the antibodies, yeah, where will the reaction come from? So that's the sentence, okay? So, okay, so this is the content. This is content of the packed cell. Is ideally 1 unit of red blood cell contains approximately 180 mils, which is like 200 mils of red cell, approximately 30 mils of plasma. We leave a little plasma because the red cell will also need dextrose to survive. The dextrose in CPDA will survive, okay? And then the anticoagulant is the Optisol. It's called Optisol again. So that one's like 100 mils. Because some of the anticoagulants would have gone with the plasma. So some of them would have gone with the. So you could have on 310 mils of. So Optisol is a crystallized solution containing sodium, dextrose, adenine, and mannitol. It's different from the CPDA actually. It's different from the CPDA. Some bag will come with Optisol, but this one has a mannitol instead of adenine. Okay, so it supports the red cell survival, extending its shelf life for 42 days. It also reduces the unit PCV to between 50 to 65%, thereby improving the flow characteristics. So, but as you are aware, you must be group identical. If you want to give red cell, you give A to A, B to B, O to O, rhesus positive to rhesus positive, rhesus negative to rhesus negative. And the storage is has to be with fridge temperature. That's the fridge temperature, 2 degrees to 8 degrees. You don't freeze red cell. If you freeze it, you are going to damage it. What's the freezer temperature? Your domestic freezer, the one you use at home. The domestic freezer, the temperature of the domestic freezer, have you ever thought of it? Eh? It's minus actually, minus 20, minus 20, usually minus 20. So, but you have freezers that are minus 40, and you have minus 80 freezer, like 2 in last suit. One in the PCR suit, you have a PCR suit in the main lab, and one in MRC lab. You know about the MRC lab? You know about the MRC lab? We have a molecular biology lab. The college has a molecular biology lab for DNA extraction, for PCR, and the lab also has a minus 80 freezer. And that's why they were doing COVID tests during the COVID time. So I've talked about glucose reduce, the frozen, pediatric. So why you want to make it glucose reduce? You want to just attach a filter to remove the what? To remove the white blood cell. Just have the so the filter can be during collection, pre-storage, or before use. You understand? As the have you have collected the blood in the bag before you put it in the fridge, blood bank fridge. There is you have a special bag for that too. Include a filter, add a filter to the bag, and let it flow through the into another bag, into another bag. And by the time it has flown into the other bag, the filter would have captured all the eh, white blood cell. Why do you want to make it glucose reduce? Okay, so you want to reduce like a typical whole blood bag has up to estimated 2 to 5 billion white cell, up to 2 to 5 billion of white cell. So by the time you are doing glucose reduction, you are reducing it to like 5 million. The filter would have captured all the white cell. So you have it cannot be completely zero. It can't be completely zero. So depending on the sensitivity of the filter, so some will reduce to 5 million, some will reduce to 1 million. Okay. So like I said, it can be pre-storage, glucose reduction, or post-storage. So the pre-storage is the patient has just donated, attach the filter, and then but if you don't do a pre-storage glucose reduction, the white cell will be releasing cytokines into the plasma, and then you will not be able to filter those cytokines. You can filter, the filter is designed to extract, to keep white cell and not interleukin 6, interleukin 7, interleukin whatever, which are the cytokines. So those cytokines can still cause febrile non-hemolytic transfusion reaction, and that's why you do a glucose reduction, because you have given a group identical and the patient is still having fever during transfusion. You checked, there is no incompatibility. You checked everything, so it could be reaction of the cytokines. You understand? And that's one of the reasons why you do a glucose reduction. But if you have not done a glucose reduction pre-storage, at least before use, you can do a quick glucose reduction by the bedside. That's the post-storage. So like those are the viruses that white cell harbor: cytomegalovirus, Epstein-Barr virus, and human T lymphotropic virus. Imagine, but if you are immunocompetent, there is no problem giving you CMV because it will not harm you. But if you are immunocompromised, CMV can develop a CMV, cytomegalovirus infection, can cause you CMV retinitis, CMV carditis, CMV hepatitis, and then we give blood that are not glucose reduced to neonates, to HIV infected patients, to transplant patients that are on immunosuppressants, you know, and then they will now develop CMV diseases. You know, they can get EBV, Epstein-Barr virus too, and then that can reactivate and cause cancers like Burkitt lymphoma, non-Hodgkin lymphoma. You know, HCLV can cause HCLV diseases too. So you can make your blood white cell free by doing a glucose reduction of the red cell. So I've talked about frozen But if you freeze, it's going to, without adding glycerol, it's going to lyse the red cell. But you must add glycerol to cryoprotect, because the temperature are going to freeze at -80. The red cells, the membrane are not that infallible now. It will lyse it and release all the contents. So glycerol is known to cryoprotect red cell. Okay, so if you want to freeze for rare blood group, Bombay phenotype. Which one is Bombay? Bombay phenotype. Yeah, lack H antibody, has H antibodies. So this is not common. So you can freeze. Okay, so you freeze with glycerol, but you must deglycerolize before use. We have a machine for that, to deglycerolize. So this is the machine, deglycerolizing machine. But they are not available, just theory, just for you to know. Just for you to know, they are not available. We are hoping that one day we'll get there, and then we'll all this in developed world, you want to do grouping up, you must specify the red cell you want to use. It's like a prescription. Please kindly make available group O positive, Bombay phenotype, glucose reduced, irradiated for these patients. But we don't do that here. You just Google and consume. You must specify. So like the wash dress, we use normal saline to wash, and this can also be indicated in febrile non-hemolytic transfusion reaction, because all the cytokines would have been washed off in the plasma, would have then IgA too would have gone. In repeated severe allergic reaction, patient with antibody to IgA, you can wash off the IgA. And then the problem is that if you pack a red cell, or if you tamper with it, it must be used within 4 hours to 6 hours. Otherwise, the quality will depreciate, just like the washed red cell. So the radiator, yeah.
Does that mean that the red cell concentrate is different from the washed cell?
It's different from.
The washed cell.
Have you added normal saline to the washed red cell concentrate? When you say wash, you are adding normal saline. You are not adding normal saline. I said red cell concentrate. You have used a centrifuge to spin. For pack cell, you have put it on the shelf, let it settle by gravity, and then wash red cell. You have added normal saline. So there are different.
So when we are to improvise, we take to vote, and we want to give, there's no negative blocks. And said we can use pack cell concentrate.
Pack cell, the pack cell.
Yes. Can we also use red cell concentrate?
Yes, yes. Then you have the centrifuge. Why not? If you have the centrifuge, this is the radiation. You know, there are some cells. There are some indications, like those with T cells defects, those going for transplants. If you want to do intrauterine, like I mentioned, you can determine whether the baby is anemic in utero by doing whether there is hemolytic disease of the fetus and the name of the Lilly's chart, Queen's chart. I hope you still remember. And then you want to do intrauterine blood transfusion. 6 months, you want to transfuse the baby. So you want to give irradiated blood. In premature infants, you want to give irradiated blood. Hodgkin lymphoma, you want to, because of the risk of transfusion associated graft versus host. Transfusion associated graft, the body of the recipient will be rejecting the red cell and then will be causing immunologic reaction. Transfusion from blood relatives is called directed donor. Your brother is going to donate blood for you. It's called a directed blood. The same father, the same mother. There is need to irradiate it. I will tell you why. HLA match products, there is need to irradiate it. So irradiation will kill the DNA in the white cell. Red cell has no DNA. Red cell has no DNA. So, and DNA is important because of the, it's going to kill the, when you filter, you are removing the white cell whole. But here, you are not removing the white cell, you are just destroying the white cell with radiation, so that the human leukocyte antigen on the white cell is also destroyed, so that there will be no reaction, immunologic reaction. Okay, so this is how it works. It destroys the DNA of the white cell, and then you use a 25 gray of gamma radiation. 25 gray, you expose the red cell, packed red cell concentrate, you expose it to gamma radiation, 2,500 rad, which is equivalent to 25 25 gray or GY. So, and then you stick a sticker. So when it's fully irradiated, it changes color, and then you remove it. Okay, so that you know that there's, the white cell has been eliminated. So if you eliminate the white cell, if the white cell is containing cytomegalovirus, containing what other virus, Epstein-Barr virus or HLV, you are going to kill everything. You eradicate it. So you can either use this method or do a filter, like make it glucose reduced, to reduce the quantity from 2 to 5 billion to like 1 to 5 million. Okay, you are going to do a glucose reduction to reduce. You can either do that or you do this. Okay, so this is we are hoping that one day we will get here. Okay, we have a, when I visited, because I trained there, I've not practiced overseas, so that I traveled overseas to see how things are done. So I saw how they irradiate cell, just like a microwave. We have seen microwave, so you just put your blood inside the microwave machine, but the microwave is emitting 25 gray. That's 2,500 rad, and then you stick your sticker on the red cell, and then you can see from the glass that adequate radiation has been dispensed. And once it changes color from red to black, then you switch off the microwave. So it's not a difficult technology at all. It is not, but it's not available. But you have, we have been improvising in Lagos. You know, radiotherapy machine. Radiotherapy machine is available at Root and Marcel Root in VI. So it can emit 25 gray. So for those that strictly need, those that have gone for transplant overseas and are back and will need blood, if you don't want to, go for transplant, allogeneic transplant, the person will be on immunosuppressants. The person will be immunocompromised. So if you give unfiltered blood, irradiated blood, then you are going to be transmitting CMV. You're going to be transmitting HPV. So what we do is just to send the blood to Root for irradiation. They use their machine, 20, adjust it 25 gray, and leave it for some time, or send it to Marcel Root. So this, I've talked about the pediatric bag, and we know the importance of the pediatric bag. Okay. Granulocyte transfusion is no longer advocated, I've told you, because you will be transfusing CMV, you will be transfusing EBV, you will be transfusing HCLV. When you have a Neupogen injection or figastrine injection that costs 9,000 per day that you can give 3 days, then the white cell goes up. So why do you want to use granulocyte? Except you want to do a stem cell harvesting. Want to do a stem cell harvesting? Someone that wants to go for stem cell transplant, okay? Whether you are the donor, which is autologous, you are the donor yourself, or if you are allogenic, you'll be prepped with the Neupogen injection, the GCSF, to boost your white cell count and stem cell. And after 4 or 5 days, you go onto the apheresis machine and then program the machine to draw only stem cell, and that stem cell will be transplanted into the person in it. The characteristics of stem cell is a pluripotential stem cell. It will seed its way into the marrow and start to produce normal cells, provided you have done adequate conditioning of the disease. That you have killed the disease with high dose chemo in the marrow. You have irradiated the bone, kill all the form of the disease, then you now give a stem cell that is free of the disease or mutation, and then through the blood, then seed the cell into the marrow and will start to produce normal cells. So granulocyte transfusion is. So I've talked about the fresh frozen plasma that must be frozen within 6 to 8 hours. The PF24 plasma, it's not waste, it's not use, it's not waste, it's not a waste. Plasma collected and frozen more than 8 hours, except that it will be deficient in factors, it will be deficient in 5 and 8. You can thaw plasma. Thawed plasma is plasma that was frozen, FFP or PF2, thawed and kept at refrigerated temperature for up to 5 days before use. Okay. Liquid plasma. Liquid plasma is plasma that has never been frozen. Just leave it. It's usually used for fractionation of the clotting factors. In fact, we use chemical method to extract the factors from it. You can pull a lot of plasma together so that the yield will be high. Yield from our own factor 8, from its own factor 8, you can pull it together and extract. You can read about fractionation. There is solvent and detergent S&D plasma, plasma treated with viral inactivating solvent, a pathogen inactivation. I will mention that again here. Okay, plasma, I'll talk about the S&D plasma later. Prior to freezing, the plasma cryoprecipitate reduce. I've talked about that. Once you remove the cryo, what is left is the cryoprecipitate reduced plasma. So, fractionation of plasma. You are going to use that to get the derivatives. The derivatives are what? Hmm? Like PCC, protobeam complex concentrates. These are PCC. So I've talked about dry plasma. Then they were using convalescent plasma during COVID. Patient that has had COVID and has recovered will have antibodies to COVID, though they do plasmapheresis. So I must mention that apheresis can be plasmapheresis, uh, leukapheresis, platelet pheresis. Does it make sense? Platelet pheresis is just the platelets. Local pheresis just the white cell. Or plasma pheresis is, or erythrophoresis, which is the red cell. Okay. So you do a plasma pheresis for somebody that has recovered from COVID, and it's assumed that the plasma will be, for you to have recovered from COVID, that means you have antibodies, rich antibody. So you do a plasma pheresis, and then you give that plasma to somebody that has COVID, that still has active COVID. So and they use it during COVID time. So the antibodies, COVID antibodies in the plasma of the person that has recovered will fight against the COVID infection in somebody with active COVID. They were doing it during COVID and during Ebola. So they have a plasma pheresis machine that can only do extraction of the plasma, not red cell. So that's the limitation. They gave us one in last week, but later they sent it to IDH Yaba for use. So during you have an outbreak of an epidemic and somebody has recovered, that's a convalescent plasma, called a convalescent plasma. So we talk about FFP. FFP must be frozen within 6 to 8 hours and must be frozen to -18 to, at least if you have a domestic freezer. If you don't have -40 freezer, once you can freeze it, it's good to go. So once you freeze it, you know all these ones are stories. Rapid freezing is recommended within 4 hours. Freezing is confirmed when the content becomes stony hard. Okay, so some instant cool freezer, you have some freezer -25 within 35 to 40 minutes. It's available, commercially available. So it's about 200 to 250 minutes plasma volume, you know, prepare from single units. Okay, FFP, and then you have a jumbo unit prepared from apheresis. In apheresis, you can program to get more. You can 600 mils. Unlike the unit of blood, the whole blood, the maximum you can get is 250 mils. But if you are connected to apheresis machine, you just continue to get more, get more, get more of plasma. So it contains all the antibodies. Of course, it must be group compatible, group identical. Because if you are giving, if you're giving O plasma to A, you know A has antigen, O has antibodies, anti-A. So it's better to give a group identical, plasma. But AB plasma has no antibody, so it's like a universal donor. Unlike O, you understand, O that is universal donor for red cell, AB is the universal donor for plasma because that's no antibodies. You understand? AB has no antibodies. But once you are frozen it, the shelf life is 1 year. You can keep it in the freezer for 1 year. That's the beauty. Once you are frozen it, within 6 to 8 hours, it can be in the freezer for 1 year. Okay, so that's the beauty of FFP. So these are the conditions when you use FFP. TTP, what's HELP syndrome, hemolysis, elevated liver enzyme, hemolysis, elevated liver enzyme, and low protein seen in pregnancy. Combination of hemolysis, elevated liver enzymes. That's HELP. We've talked about TTP. We talked about HES, thrombotic thrombocytopenic purpura. HUS is hemolytic uremic syndrome. DIC, disseminated intravascular. We're going to talk about DIC later. DIC, disseminated intravascular coagulopathy. Vitamin K deficiency. Vitamin K deficiency bleeding can give effect. You can give because of the content of clotting factors 2, 7, 9, and 10. In vitamin K deficiency bleeding can give FFP. Massive transfusion, we talk about it, replacement fluid during therapeutic during plasmapheresis. Because you are going to be extracting 600 mils. Oh no, therapeutic, okay, we talk about therapeutic apheresis, plasmapheresis. It's different from donation. So some rheumatology patients have a lot of antibodies, autoimmune antibodies, that in the plasma, SLE, rheumatoid factor disease, and so many of their conditions, destroying their organs, causing anemia. You can connect them to the plasma pheresis machine, draw out their plasma containing the various antibodies to their organ, and then replace with good compatible plasma of another person so that they are not plasma deficient. That is the therapeutic plasma pheresis. Okay, so the dose is 10 to 15 mils per kilo of FFP, and should not be used as plasma expander. So rather it should not be abused because of the risk of infections like what and what that will be in the plasma. No, CMV is not in the plasma. HIV, hepatitis B, that is C, and and there are so many infections, but they are not common in this part of the world. You have the trypanosomiasis, all this. You have bloodborne. Syphilis is also in the plasma. Okay, so and that's why we do VDRL tests. So you don't use it when it's not needed. So like I said, it's stored, shelf life is 1 year. Once you are frozen, you keep it for 1 year. Okay. So this is the cryo. I've talked about the cryo. But like I said, cryo is because of the reduced volume. You want to reduce the volume, it's like 15 to 20 mils. So you may not need to do grouping and cross matching because it will not reduce any. So, but it is also deficient in factor 9. You know? So cryo contains, these are the contents of cryo. So this are when you use cryo, because it has factor 8. FFP can be used for temporary replacement therapy in this condition. Cryo is more suitable because it's more concentrated, because you don't even have cryo here. So you don't have FFP. So cryo is also stored like FFP, and it also has a shelf life of 1 year. It's for -20, -40, depends on the freezer you have. So these are the content of cryo. So factor 8C, factor von Wieber factor, factor 13, fibrinogen, fibronectin, those are the contents of the cryo.
So I want to ask about this because
Mm.
you said that it is the spinal plant
No,
after
the sediment, not the supernatant.
segment.
When you thaw the FFP, you know FFP is frozen. You leave it out and thaw it, then you spin. The sediment, you now decant the supernatant as the cryo pour plasma. Cryo pour. The sediment is the cryo, which is like 15 mils to 20 mils. And that is the content.
Still contain the platelets. The platelets
And I said the platelet would have been destroyed with freezing because platelet is stored at room temperature 20 to 25, so it will not contain platelets. Once you are frozen, even in the fridge, if you put it in the fridge, platelet is destroyed. I said how we get fresh whole blood here for platelet concentrate because we don't have the machine. We bleed donor, put the fresh whole blood on the shelf, waiting for screening results. When the screening result is out, HIV is negative, we now transfuse fresh whole blood that is supposedly rich in platelets. But once you have put that fresh whole blood in the fridge, it will be destroying the, not to talk of freezer. Does that make sense? From no, cryo cannot be from fresh blood. You must have frozen. Cryo is from FFP. You must have frozen and thaw. I've said that 3 times today. I said thaw, defrost. After that, how can it be cryo from FFP, whole blood? Hmm? Supernatural remain after removal of the cryo from FFP. That's cryo reduced plasma, not cryo itself. Not cryo itself. Uh, sorry, why not? I said that it will be deficient in factor 8, von Willebrand factor, because they have removed it and has gone with cryo. It will be deficient, so it will not be useful for hemophilia patients. So we'll talk about platelets and then we'll round the lecture up. It's 2 hours, it's going to be 2 hours. I hope you have all enjoyed yourself, except those that are late. So you are going to lecture them when you get to the hostel. I hope you'll be able to do that. Eh? You will not be able to do that. You can't guarantee. You are shaking your head. Okay, we have two types of platelet. I've described the two types. So because to save time, we need to narrate it instead of going through the slides. Okay. Like I've said, describe the cold centrifuge produced. That means we need a triple bag. How do we get a cold centrifuge produced from whole blood, platelet concentrate? You spin, you decant the supernatant, that is PRP. What is PRP? Platelet rich plasma. Okay. You now spin the supernatant and then that will be, then decant the supernatant as the plasma. So if you can freeze within, that will be FFP. FFP. If you cannot freeze, that will be just liquid plasma. If you cannot freeze within 6 to 8 hours, it will be liquid plasma. So that's one way to produce platelets. So platelets concentrate from 1 unit of blood bag. For you to have an appreciable rise in platelets, because that will raise your platelet count to like 3,000 to 5,000. 1 unit. If you are produced, post centrifuge produce, and somebody has thrombocytopenia, 20,000, bleeding, what's the normal platelet count for you and I? Huh? 200. It's a range. Eh? It's a range. Your own will be different from our own. What's the range? 150 to 400 for Caucasian, but can be as low as 100 to 400 in us, in black. So platelet count, your patient platelet count is 15,000. You have done a full blood count and it's bringing 15,000. And then you do a concentrate, you want to give a concentrate that will increase it by 5,000. How many units will you need to raise it to 100,000? Can you appreciate this challenge? So they don't give a unit concentrate, platelet concentrate. So you have to pull 6 units from, a whole blood bag is from one donor. Or can you donate 2 units at a time? No. So it has to be the same group. Don't forget it's plasma. You cannot give group incompatible, group non-identical. You cannot give. It has to be group identical. So what they do in developed world, before they even dispense platelet concentrate, is to identify group identical 6 units from produced from centrifuge, and then you mix them together, and then you dispense like that. That will raise the platelet count to like what? Like 30, 40, 50,000. Does that make sense? But here, the platelet preparation is not adequate. It's not adequate because of the shelf life. Shelf life with an agitator is 3 to 5 days. So if they prepare platelet and it's not used, even with an agitator, you will see an agitator within 5 days, it becomes a waste. So usually they do it on request. And if they do it on request to get six the same blood group, so you just get it in piecemeal. You need platelet concentrate. We'll give you 1 unit. Go and be using that one first. 2 units, it doesn't make sense. But if you do apheresis platelet collection, it's going to concentrate the platelets as it's withdrawing it from the blood. It will concentrate it into the bag and then return the remaining component. It's equivalent to 6 co-centrifuge produced. So 1 unit of apheresis is equivalent to 6. And that's why it's more expensive. It's like I said, it's like 700K now for 1 unit. And then you're going to be taking 2 units of apheresis, 3 units. You are spending over 1 million alone on platelets. Don't forget the cost of chemo, cost of bed, cost of admission, cost of, and then you take it after 1 or 2 weeks, platelet count drops. Can you imagine? Is it sustainable? It's not sustainable. So those are the two from platelet rich plasma and apheresis. That's how you get apheresis. Like I said, is available. You have a machine in Yaba, IDH, but it's not, we're not using it for one reason or another. I don't know. But the one in Surulere is active. And they have another one at Lut, but I can't confirm that now. So those are the 3 places. If Lagos has 2, how many would the president Ogun, Oyo, Osun, abi Nasarawa? So that's the platelet rich. And this is how triple bag for platelet production. You have bled the patient with triple bag. So this is the platelet rich plasma. This is how it looks, like 200 ml. So this platelet concentrates. So this is apheresis platelets. But at times you can do random apheresis platelets, or you can do HLA matched donor match. You can do HLA map. HLA, human leukocyte antigen, is also present on the platelets. So you can do HLA matching before you do apheresis. So you have a therapeutic platelet transfusion. So this is when you use platelet concentrate or apheresis platelets. When you have aplastic anemia, leukemia, radiotherapy that is going to destroy thrombopoiesis and cause thrombocytopenia, chemotherapy that will destroy thrombopoiesis and cause thrombocytopenia, aplastic anemia myelofibrosis, the marrow is fibrosed and is not producing red cell, not producing platelets, not producing anything. MDS, these are the conditions that you may need platelets. So patient can be symptomatic. Patient can be, when you have a low platelet, it can be petechia, can be purpura, ecchymosis. These are the symptoms: mucosal bleeding, and then spontaneous hemorrhage can cause. So we talk about thrombocytopenia, indication for use of platelets concentrates. So I'll just summarize because of time. Whether there is symptoms or no symptoms, as long as the platelet count is less than 10,000, you have to give the platelet concentrates. Symptoms or no symptoms. What is the implication of not using platelet concentrates? Because you don't want to wait on the patient bleed into the brain. Okay, but if the patient has a platelet count of between 10 to 20,000, the patient must be symptomatic for you to use platelet concentrate. Patient must be symptomatic, such as anemia, fever, or patient is going for invasive procedure. Okay, so these are the other conditions where you can use platelet concentrate. So but like I said, if patient is asymptomatic, you need to wait for platelet count to drop to 10,000. But if the patient is symptomatic, 10 to 20,000, you have to do platelet concentrate. Okay, but if the patient is going for surgery, depending on the type of surgery, okay, we determine the type of, if the patient is going for general surgery, you want to use platelet count of 50,000 and above is the minimum you can go below. Because is 50,000 and above is sufficient for most invasive procedure, including gastroscopy, biopsy, insertion of the indwelling lines, transcopy. So anybody that has platelet count of less than 50,000, you have to be careful. You want to do any procedure, okay, so that the patient will not bleed from there. So, but if patient is going for neurosurgery or ocular surgery, then platelet count must be up to 100,000 and above. 100,000. Surgery, ocular or neuro. We are now faced with a situation: patient has platelet count of 10,000 and has bled into the brain. Okay, and then you have invited the neurosurgeon to come and do a borehole to remove the blood in the brain. Then you are faced with the challenge of raising the platelets to 100,000, and then your platelet concentrate will raise it by 3,000, and they are not readily available. You come today, come tomorrow, come today, come tomorrow. There is no, we have done. You can see the challenge. You can see the challenge we face in practice. That's the challenge we face in practice. Then this neurosurgeon will tell you, it's no go area, because if they put their drill, the patient will bleed more into the brain before the blood inside comes out, because there is no primary homeostasis, adhesion, platelet aggregation is deficient because of the low platelets. So bone marrow biopsy we do, because you cannot insist on, because most of our patients have problem with thrombocytopenic leukemia. You want to say you want to raise it, you won't get a diagnosis. So for bone marrow biopsy, no matter how low the platelet is, you see platelet count of zero. So we just put our needle and put pressure more than allow the so pressure will act as our hemostatic plug, and then we remove, but they still bleed, but it's still better you get a diagnosis than not having any diagnosis. But don't try that with lumbar puncture, because if you do a lumbar puncture with platelet count of less than 50,000, patient will bleed into the CSF, and that will cause headache and then go to the brain, and you understand. So these are what I've explained in surgical procedures. How low can you go with your platelets? In surgical, I've explained this. This is the dosage, I've explained it. The usual dose for platelets is 1 unit for every 10 kilo. So if you are 60 kilo, you're going to need 6 units. And it has to be group identical. You cannot use group A, group B, group C. So you need 4 to 6 units depending on your weight or platelet concentrates. But the minimum standard is usually 6 units. So platelets usually be ABO type compatible. And this is what I've explained about the dosage. It's 5 to 10, but it can be 3 depending on how rich the platelet of the donor. So like this is important. Platelet is stored between 20 to 24 degrees. What is storage for red cell? 2 to 8. What about FFP?
-20.
-20 and below. Can be -40, minus whatever. So what's the shelf life for red cell with CPDA? 42 days. What about for FFP?
1 year.
Cryo, 1 year. Platelets with an agitator is 3 to 5 days. If you don't have an agitator, what I will show you an agitator, how it looks. It agitates you after producing the platelet, you put it on the agitator, agitates the platelets, rock it so that it doesn't get activated. So if you have an agitator, it's 3 to 5 days. Without agitator, it's 24 hours. You have to use it that same day. So if you are planning to buy a cold centrifuge, you must buy an agitator along with it. If you are planning to buy a apheresis machine, you must buy an agitator with it. You know, that's why they don't produce platelet every day. So within 5 days, if there is no demand request for platelet, you have to discard it. And triple bag is more expensive than double bag. Double bag is more expensive, so the cost of production is high. So this is how an agitator looks. It can be just, it will be rocking it. It can be this, it can be that type. You can layer the platelet on the agitator so as to prolong the shelf life. To prolong it to what? 3 to 5 days. But at times you don't give platelets. Even when there's thrombocytopenia, patient has platelet count of 5,000 and then you cannot give platelets. Because if patient has antibodies like in ITP, immune thrombocytopenic purpura, the patient has antibodies to platelets. So if you give platelets, the antibodies will be destroying the platelets. But if the platelet comes down to 0, you won't mind to give platelets, because you don't want to prevent bleeding into the brain. Platelet count is 0 and there's platelet concentrate, somebody has ITP or not, you still give, you just watch whether it's going to be destroyed or not. You understand? But the treatment for ITP is not platelet concentrate. Despite, for example, if the platelet count is like 20,000, 30,000, you use IVIG, which is intravenous immunoglobulin. You use steroid, you use to stabilize the membrane. So we'll talk about ITP later. So I think this is summary. You can see the shelf life, pack cell, platelets, FFP, cryo, and storage temperature. At times they say 1 to 6 degrees or 2 to 8. You can see with agitation and FFP, you can see that. So I think so. The derivatives, like I've said, is the factors concentrates. So like the factor 7, factor 8. So thank you for listening.